this is perhaps the most exciting part of the program. This is where you get to interact with the doctors. We have a lot of questions. What we're planning on doing is we will address some of these online. We'll follow up with the doctors and feed those out to make sure that all of the questions are answered in time, because we know that this is really important to you. So let's get started. We have a question from a parent. And the first question is, what tips do you have for parents, teachers, family, and friends who may notice early warning signs? How might they address the issue without causing harm to the relationship? And this is for the entire panel from a parent.
Could you repeat that, please?
Yeah.
Yes. So what tips do you have for parents, teachers, family, and friends who may notice early warning signs? How might they address the issue without causing harm to the relationship?
Causing harm to the relationship with the kid?
Presumably the relationship between the intervener and the person suffering with the mental health issue.
Well, I have one particular perspective on that, which is that I think depending upon the age of the child, being as direct as possible usually is better than kind of walking around what the issues are. The main thing you want to do first is get the kid in for an evaluation. And that will scare a child, and it may scare an adolescent as well. They may think that they're going to be pulled out of school, or that it's because they're bad, or because they're going to be taken and given to another family, or you never know what attributions they're making. So presenting it in a very humane way, as not that much different than a regular medical appointment or a dental appointment. It's just one where we're going to find out why you get angry so often, or why you're having so much trouble attending at school. In terms of involving the teacher, and if the teacher is already observing warning signs, of course that's a useful piece of information. But they don't necessarily need to know what the outcome of that evaluation was. And I would use a sort of principle that tell people if you think there is something that they can do to make your child's life better, not just because they're asking. Because there's a lot of gossip that goes along, like what exactly is it that's wrong with your kid? And they don't need to know every detail. And part of what kids get very angry about is the notion that lots of people are being told about this and they don't have any control over the information flow.
Yeah, I think that our clinic takes about 5,000 new patients a year between the ages of 4 and 18. And that's a very frequent question from a parent, or occasionally from a teacher, but usually the teachers have talked to one of the parents. There are some complicating situations, but most of the time what we do is, and you'll probably hear this from all of us, although David's system is different, but is to recommend that discussion the way we try to present it when it's difficult, because the call usually comes for the ones where it's difficult as versus the easy solutions. And that is that we assess, we have the parents tell them that we're going to look at the family situation in the same way David's talked about it. And so we have the parents come in, or at least one parent, and we simultaneously do the evaluation with the child and the parent, so that the pointer is not entirely on the child or adolescent, but it's on the entire family situation. And we are using, of course, most of that time with the parents, unless, this is not uncommon the case they have a problem, but most of the time we're using that time with the parent to find out more about the child. And they'll be in 2 separate rooms, and then we bring them together to suggest that maybe they want to make an appointment and come back.
I would say, when you're approaching, whether it's a child or a parent, that you're concerned about the child in question, really normalizing that, mental health problems are so common, so they don't feel like they're the lone stranger, because they definitely aren't. And sort of mentioning that bringing mental health into treatment, the great news is we do have treatments that are effective, and there's really no reasons believes that mental health illness should be treated any differently than medical illness. We know it's a illness that's caused by problems in the brain, just like, like diabetes might be caused by problems, with your pancreas, something. So kind of normalizing it, maybe even putting it into language that, these are illnesses that can be treated and have a medical component. I think also when approaching a parent, often parents feel very, very guilty, and sort of letting them know, your child, no child comes with a textbook. They kind of get to us how they get to us, and if there's, some support to help you and your child, why not take advantage of it? This is, something we're all kind of learning together.
I think these are all very good points, and I think the only thing I would add is to do with when you might have this conversation with your child. And often, I think as parents, we're feeling very stressed about something, and the moment when we feel stressed is when we want to sit down with our child to talk about it. But I'm sure all of you know, a lot of adolescents, their repertoire for conversations if the parent sits them down and asks them questions are, yeah. So I think it's often best not to take that moment and not that setting, but maybe when you're on a walk together, when you're going on the car, something like that. And also take the cue from your child. So I think, when they're upset about something, they've, gone to a party and it's gone really badly and they're upset about it afterwards, and the next day they're still reflecting on it, that might be the moment when you're having a walk that you bring it in, I think. Because it's very important, even though it's your own children, that it's a collaborative conversation, and you take the moment when they seem to be open to discussing it, not when you're feeling most stressed about it.
This next question is for Dr. Fitzgerald. It's from a teacher. What happens when parents reinforce, quote, the fear of threats, unquote, and overly protects children, preventing them from practicing the skills they need to overcome anxiety?
So I think, kind of similar to the previous response I gave, trying to partner with that parent. I think one thing that can, of course, make a parent feel defensive is if you say, hey, you're accommodating your kid, you're screwing it up, and kind of instead taking the tack that, any parent, the thing that we very much want to do is protect our children from harm. But there's this funny way that anxiety works, that when you offer protection, that can kind of reinforce that, lo and behold, that anxiety really is something real, that threat is really something that can hurt you, and in fact it's not a realistic one. And so there are ways, to gently encourage kids to kind of face their fears to where they can overcome them. So that's the type of language I might use, and then of course helping that parent connect to treatment. And there's, we've talked, I think, a little bit about the difficulties with access to trained therapists, but there's also many good books and online recommendations that people could get to help educate themselves about anxiety and how to talk to their kids and maybe engage in care to even seek it, where to find it, who to look for, that sort of thing.
Great question, whoever submitted that.
So
this is for the entire...
the word overprotect is very appropriate, isn't it? Because as parents, we do protect. That's one of our goals in life. And so finding where's the balance between protection and overprotection is a very difficult one. And often I think with parents, the first thing to do is get them to reflect on, the strategy you're using so far. Is it really working? Is it building confidence in your child or not? And I think if you feel, well, it isn't working, then it's a matter of really experimenting and saying, well, let's let go of a little bit of this protection in a graded way and see if that helps build confidence, and experiment. Because, there isn't an absolute level, but I think the first thing is to realize, well, what I'm doing at the moment isn't achieving quite what I want to build the confidence of my child. Let's ease off a bit and see how it goes. And then, of course, therapy can give you quite a lot of advice on that as well.
This question is for the entire panel, and perhaps, Dr. Clark, we can start with you on this one. We've been talking about this very issue for the last couple of days. It's come up. How are research programs including cultural diversity? Are there similar situations in African American, Hispanic, Asian, and other cultures?
Well, I mean, mental health problems are no respecter of differences in ethnicity. Every group is vulnerable to them. The research on psychological treatment seems to suggest that the treatments work pretty well for people with diverse different backgrounds. But of course, sometimes accessing them has different requirements for different groups. In England, we have a very large program called Improving Access to Psychological Therapies, which takes the sort of therapies we've been hearing about today and on a state system, gives them to about 1 million people a year. And you could do the same in California. Your millionaire's tax generates $2.4 billion, which would allow you to do 3 times more than England's doing at the moment, and your population is only 2/3 as large. So it's really possible. But we've found in order to get really good results with people from all the different communities, you need to tailor the treatment somewhat. So we have quite a lot of people who English isn't their first language in some areas, and we use therapists who speak other languages. We translate all of the materials into other languages. We also try and deliver the therapy not just in a hospital setting, but in community places that are linked to where people would normally come in for therapy. And those all seem to be very helpful. We recruit a very diverse workforce for our therapists as well, and that can be extremely useful. And we try and give patients a bit of a choice about the particular therapist that they might see, so that, you know, if you're a woman and you've been raped, for example, then you would predominantly want to see another woman, but not always, and you need choice about that. But also, we try and give people choice in terms of ethnicity sometimes, if that's a big issue for them.
One of the areas in which we've seen this be a really important variable is in the studies that we've done in the different countries, so that we developed our program originally in Iceland, which is a rather homogeneous and small nation. And then when we moved to Portugal, we had to completely redo the examples and the illustrations so that they were culturally sensitive, and the same way with Greece. So that's one way. I think the second way this is really important is, even though the diagnoses are the same, there's a difference in the rate of certain symptoms amongst different cultural and diverse backgrounds. So for example, among Latinos, there's a greater emphasis on the somatic symptoms associated with depression as versus some of the emotional ones. So there's that level. And then the final level I learned very interestingly and fairly recently when 2 postdocs and I were doing a workshop for the Georgia Psychological Association on involving parents in the treatment of depressed adolescents, and somewhat taking from the work that David and I used to be at the same place, and he taught me a lot about families. And one of the things that we discovered by incorporating an African-American postdoc into the presentation when we were talking about parents and reinforcement, and the issue of that relative to punishment came up, and the culture is very different in the way that it utilizes and apportions reinforcement and punishment. And it turns out that there's a lot of research to show that there are differences in families, so we have to be sensitive to that in our treatments, although the principles underlying the treatment remain the same.
Dr. Miklowitz, you wanted to say something?
There are a couple of societal problems that relate to this, and one is in the child psychiatry literature. There are some diagnostic biases. When you have kids come in who are African American, they're more likely to be diagnosed with oppositional defiant disorder and conduct disorder, whereas a white kid with the exact same symptoms would be more likely to be called a mood and anxiety disorder. That is a bias that we're just starting to recognize. It also shows up in adults. There was a study not too long ago that showed that the psychosis was being overdiagnosed in some African American populations, and when they drilled down into their data, they found out that street language was being coded as thought disorder by the investigators who weren't familiar with that kind of talk. So I think it's really very important to know cultures, how kids present in different cultures, what families believe about what is and isn't mental illness, whether they use terms like bipolar or depression, or whether they're just talking about being angry or mad. That's what we call cultural humility, being willing to say what you don't know about a culture and learn from the person in a more collaborative way.
Thank you. The next question is from a student for Drs. Fitzgerald and Clark. Is there a different approach to treating panic disorders other than those associated with generalized anxiety?
Yes. The treatments are quite different, at least the ones with the strongest evidence base. In panic disorder, you tend to have a sort of vicious circle where people notice missed heartbeat or feeling short of breath and things like that, and they tend to rather automatically think there's something very seriously physically or mentally wrong with them. Thoughts like, I'm going to die, I'm going to have a heart attack, I'm going mad. And the problem is that once you have those thoughts, if you believe them, then of course your body reacts to that and you get a big increase in anxiety, and it spirals up very quickly into a panic attack. So the art in treating a panic disorder is to help people understand that vicious circle, and then help them discover that although alarming, these sensations are quite harmless. And it's a very active therapy. You'll do lots of exercises to test out your beliefs. So, for example, if you are someone who, in a panic, get a racing heart, feel short of breath, and you think you're dying, we might first look, in reflecting what I said in my talk, about what are your safety behaviors. What are the things that you do at that moment to try and take away the sensations? And you might find that the person would tend to rest at that point. They might sit in the chair, slow down their breathing, try and relax, and if they don't die, which they don't, they'll think afterwards, well, that's not because these panics are not dangerous, it's because I just managed to save myself in the nick of time. And so in therapy, you've got to, check that out. You've got to do the opposite. You might say, well, the problem with taking a deep breath and resting at that moment is that it sort of works from the idea that there's something wrong with your heart, but it also works for the vicious circle model. In both cases, it should help. So it doesn't get us anywhere. So could we do something different in therapy that would? So instead of relaxing at that moment, could I suggest that you sort of get up and we do a little bit of exercise, and we might run like this in the therapy session, and I say, what's happening, how's things going on your heart? So it's getting a bit tight now. How likely do you think you are to have a heart attack? And they say, well, I don't know, about 30%. And say, okay, but you remember when this happened last time, it distracted you, all the sensations went away. Would that happen with a heart attack? No, not really. So let's go for the burn. Okay. And like that. Okay. And then, how do you get on? So it's a really quite practical therapy, focusing on testing out these particular beliefs you have about how dangerous the sensations are. Generalized anxiety is much more to do with worry that seems out of control. And you spend quite a lot of time looking at the advantages and disadvantages of worry, because people have positive beliefs about worry. They think they'll solve certain problems, and you have to deal with those beliefs. So it's a very different therapy.
Well,
I'm sorry you have to follow that up.
Yeah, I know. I was going to say, I really can't top that. I was thinking, what could I do? I could try a cartwheel. I'm not going to go there. But I think to Dr. Clark's point, part of the challenge, for a clinician at the very beginning is the diagnosis, right? And so you're trying to assess, if panic attacks, which is these very physical symptoms, my heart is racing and I'm short of breath and maybe I'm sweaty and this is just freaking me out. I'm afraid I'm having a heart attack or I might die. is that kind of a standalone thing? It's popping out of the blue. Maybe it's occurring in certain kind of general situations, like I feel in a closed-in space. Or is that occurring secondary to something else, such as generalized anxiety disorder, whereas this idea about I worry because maybe if I worry enough, I'll prevent, a bad outcome, such as doing poorly on a test or a friend, disappointing a friend. So diagnosis at the beginning is important, so you can sort of prescribe which type of cognitive behavior therapy. Where do you target it? Do you target it at sort of correcting the belief that worry is going to help me, because that may be most appropriate for the generalized anxiety disorder, and you can get panic secondary to that? Or do you target it at this kind of practicing these physical symptoms and realizing that, lo and behold, my racing heart isn't going to hurt me?
Thank you. This next question is from a parent for Doctors Craighead and Miklowitz. How do you know the difference between a period of a teenager's feeling sad or blue and true depression? Many teens are moody and oversleep, for example. A lot of the typical symptoms in depression also look just like teens being teens. So when should a parent be worried and seek help?
That's a very good question, and was actually something early in the talk that I made, the distinction between distressing symptoms, which is pretty characteristic of the sort of angst and the teenage disorder, and some sort of what we refer to as teenagers, sort of natural oppositional. David's alluded to that. I think it's when obviously you want to recognize it as soon as possible. The early kinds of things that frequently show up are sleep disruption. If the young person, particularly if they're waking up very early, and that's uncommon for most teenagers. Even if they go to bed late, they tend to want to sleep late, but if they're having disrupted sleep. And there are other of those symptoms. It's when it gets to the point that it's interfering with either the family or the school or social functioning behaviors that you want to start attending to it. And then we already discussed earlier, when that has lasted for a certain period of time, and clinically it's going to take 2 weeks of most of the time for most of the days to reach a diagnosis. But if at all possible, if that's interfering with life, you want to make that decision earlier. While I'm speaking, if I just say one other point to set up David's answer, I think, is that one of the things that happens so often is that somewhere around 30% of youth with bipolar disorder present with depression. And it's really critical to look at that family history and what's been happening cyclically in the person's life, because if you treat the person with bipolar disorder who initially presents with depression as unipolar depression as versus bipolar depression, you can very easily make them worse, and you can take it from there. But I think that's a very common thing that we see happen in the clinic, and it can be with disastrous effects for the person.
Yeah, I agree with, I could just say what he said and move on, but I think the issues are not only about depression, but about hypomania and mania as well, which can also look like teenage behavior. What developmental psychologists say about the period of adolescence is it's marked by mood instability, family conflict, and an increase in risk-taking. All of which, by the way, are key symptoms of mania. So they can look exactly alike. But there is a very important distinction between do these symptoms occur in clusters together at the same time, or are we just seeing one symptom that gets out of control? So let's say it's sleep. Yes, maybe they have some nights of poor sleep, but does it go along with low mood, disinterest in things, low motivation or irritability, more energy the next day, grandiose thinking? So we look for 2, 3, 4 symptoms to coexist, plus there has to be, as Ed said, some evidence of functional impairment. If there is no impairment being brought about by the sleep problems, then it may not be something to be concerned about. But it's still a bit of a judgment call on the part of parents to know what is within the realm of this child's typical behavior as they're entering adolescence, and what could really seem like, say, a delusion or hallucination or mood that's so out of control that it really needs to be, a doctor needs to be brought in. I usually tell them it doesn't hurt to have an evaluation if you have significant concerns. You may not want to do anything with the recommendations, but at least you'll know what the doctor's opinions are.
That's good advice, thank you. Next question is for the entire panel. It's an interesting one. We've had several questions regarding medication. To what degree is medicine the only or best option? What are the long-term effects of children being medicated? Is it forever?
You can go first.
Okay.
Okay.
So I'll take that one. I think, I might have mentioned, and I thought maybe Dr. Clark was going to also mention, I'm not sure if he did today, that oftentimes families do prefer psychotherapy first. And if it's one of these, quote, evidence-based psychotherapies, there's good reason to believe, yes, that should be tried first, especially in mild to moderate cases, and to some degree depending on which disorder. However, if, either a child gets several weeks or a month or more into a therapy and really can't engage, they're not getting better, and or B, the child is so severely affected by anxiety, depression, OCD, that they just aren't functioning. In either of those two cases, I have a pretty low threshold for starting a medication because they often do work. And as you saw from the slides that were put up, whether you're talking about depression, whether you're talking about anxiety, OCD, or maybe some combination of these, we do know from research that therapy plus medication together tends to have the best effect for the most people. This was applied, over 10 years ago now for selective serotonin reuptake inhibitors. So these are your Prozacs, your sertralines, your Celexas, your Lexapros, medicines that are very commonly used to treat all three: depression, anxiety, OCD. And there was concern that these medicines, particularly in youth, may be increasing the risk of suicidality. So what studies had found, not completed suicides, but increased suicidal thinking. As sort of the time has gone by and people have studied closer and closer into this data, it appears that this risk may be slightly less for anxiety than if you have a depressive disorder. And if you combine the therapy, cognitive behavior therapy-based treatments, with the medicine, it's protective against this risk. And again, the risk of suicidal thinking rather than completed suicide. So I have a very low threshold, and you're monitoring these kids. Typically, I prescribe in the context of CBT. I think that the potential benefit of a medication in a severely affected child or a child that's just not getting better from CBT alone is very, very high, far outweighs the risk that I think can be managed.
So I'll make two really quick comments. One is that I put one of the large studies up, but there are two of those that we've done. And the choice, it turns out, of whether because people were randomized, 100 to medicine and 100 to CBT, what they said they wanted beforehand really didn't make any difference. It was much more important in terms of whether it matched the particular brain types. That's the first thing. The second thing is, I didn't talk about it here, but those people who failed to the monotherapies, that is, to a medication or to CBT, were subsequently given the opposite in combination. And it turns out that has the same effect as the two studies. You showed the CAM study, I showed the TAD study, that showed about 80 to 85% of response to combination. The good news for you is that, at least in our hands, when we switched people who didn't respond to medication to CBT, that was just as effective as the other way around, that those who didn't respond to medicine and then got CBT or vice versa. It didn't matter the sequencing, so that if you go for therapy and it doesn't work, there's still the possibility of combining them, or if you go for medication first and that's not having an impact, they still may be interact in a positive way, so that in combination they're still going to work. So failing one doesn't preclude responding to the other or the combination.
I would say one more thing about that, and that is that failing a first SSRI medication doesn't necessarily mean you won't respond to a second or even a third. So I think that that's important, because we really don't have good predictors of, what is it about a certain person, whether it's genetic or in the brain or behavioral, that which medicine is going to work best for which person. The way that we choose, the best way we know to choose right now, is based on family response. So if you have a first-degree biological relative that had an awesome response to Prozac but did nothing on Zoloft, you're going to pick Prozac for that kid. With that said, there have been follow-up studies that have looked at switching from one SSRI to another one, fluvoxamine, for example, to fluoxetine. And those that failed the first one, 70% of them got better to the second one. So I say that because I really think that's a message of hope. On the one hand, you can try again, you may have better success, although it's also a plug for more research, because we need to do a better job at identifying which kid is the best match for which medicine.
I think these are all great points. I wasn't entirely clear that the question was about SSRIs. They're more about medications in general. And I think the story we tell could be quite different if we're talking about second-generation antipsychotics, which are being used many times for kids with agitation. These are drugs like Seroquel, Abilify, risperidone that I see kids on all the time. Antidepressants are a little bit easier to take than those other medications. There are some concerns about taking antipsychotics because kids put on a lot of weight, and you can see early onset diabetes in kids who've really dramatically gained a lot of weight as a result of taking these medicines, or it can aggravate a pre-existing weight problem. I think for parents, the issue is often, am I medicating my child for a short time, or is this going to go on forever? So is he going to have to take this when he's 50 or 30? And in fact, we don't know. I can tell you the long-term follow-up of disorders like bipolar disorder are looking better than we thought, in the sense that a good 25 to 30% of kids seem to be okay when they're in their early 20s, even if they're not taking medications. So there is a subpopulation, we don't know who they are, unfortunately, ahead of time. There's a subpopulation that may not need heavy-duty medications to get stabilized. I usually tell parents to think about it as an experiment. Their kid is having a tough time and is not functioning in school. It's worth trying a medicine for 3 months, 4 months, to see if there's going to be an impact and what the impact is on the family. Maybe that's going to be important information about whether you continue on. But I think when you enter it with the assumption that we're making a forever decision, that's incredible guilt for the family to have to walk around with.
So I come from England, and we use a lot less drugs in England. We have a government body, the National Institute for Clinical Excellence, which is charged with reviewing the evidence for interventions across the whole of medicine, and then issuing clinical guidelines about what has got an evidence base and what doesn't. And it's not linked to any professional group. And when you get guidelines like that, they tend to be a little less extreme one way or the other. I think what those guidelines would say in common mental health problems is you need to look very closely at what the diagnosis is and what the severity of the problem is. For most problems, you get some evidence that things that were originally developed as antidepressants, SSRIs, have efficacy. But certainly in depression, they don't separate from placebo in the mild to moderate cases. So we would say do not give them in mild to moderate depression because it's not superior to a placebo tablet. It's got more side effects, so why? For the more severe cases, then we would say there are sort of two considerations there. The first, obviously, is patient preference. So some people would prefer to have medication. And there's good evidence that if people have a strong preference for a treatment, they tend to do better with it. So if you have a strong preference for medication and it's a more severe case, it's a very good idea for you to have it. But the same is true the other way around with psychological therapies. And as we were just hearing from Kate, there are public surveys looking at this. And in general, there's a preference about 3-to-1 for evidence-based psychological therapies. The other thing, of course, to look at is, not just getting over your current episode, but the long-term outcome. And there, the picture really depends very much on diagnosis. So if you're looking at depression in the sort of moderate to severe range, then there's pretty good evidence, and you saw it on 2 slides this morning, that combined treatment tends to give you a bit better response rate initially, and you don't seem to get a sort of downside in terms of long-term outcome. If you look at panic disorder, there's a trial by David Barlow and colleagues here in the US, which unambiguously showed that combining medication with psychological therapy gives you a worse long-term outcome. So you have to look at the diagnosis and make the decision there. NICE recommends both medication and psychological treatment in the more moderate to severe cases, but it does actually give its highest recommendation for psychological treatments, assuming that fits with patient preference. And the reason for that is that, of course, in a psychological treatment, you aim to learn something new about how to manage your emotional problems, and the idea is that that learning stays with you. And so when things go wrong in your life in the future, you might have a reduced risk of a reoccurrence. Of course, with medication, you could achieve that by taking the medication for the rest of your life. But I think in England, we would say, why don't you take your first choice, if you want the sustained thing, of trying to learn a new skill, and then you don't need to keep on doing that. The pattern is different in the US to the UK, and one reason for that is the US is the only one of 2 countries in the world that allows television advertising of psychotropic medication. The other one is New Zealand, and your prescribing rates are just phenomenally higher than the rest of Europe.
And I'm not sure if this contributes to that statistic or not, but I think another challenge that we have, like one of the things you've done so beautifully, David Clark has in the UK, is making the psychotherapy, the evidence-based psychotherapies, more available to more people. I think one of the challenges that we have in the US is there are very few mental health providers in general, and I think you saw on, was it your slide? Ed's slide, that in the example in California, even fewer when you're talking child psychiatrists. So oftentimes kids that are sort of just out there, they have access to a general practitioner, a primary care pediatrician, who they can write a prescription, and they could recommend CBT, but it's sort of good luck finding it. So I don't know if that's in addition to the advertising, that may drive our statistics up, more meds, less therapy, but I think it is very important that we get kind of these psychotherapies out, whether it's through the schools, whether it's through integrated behavioral health, like I think what you guys are working on, and something called Ohana I've been hearing about. Because I do agree, this idea that a psychotherapy, even if you do start it with a med, may give you a better chance of going off the medicine because the psychotherapy is learning, more durable effect.
Yeah. So it's really important to try and set up the system so that you have both options available to families. And at the moment, as you've heard from Kate, quite often you find that you're going to someone who really can only give you access to one of these modalities. And that's really a shame. So we want to evolve systems so that the advice you get isn't largely determined by what the person themselves can personally do, but is a bit more impartial.
Dr. Miklowitz has to catch a flight, but can you give him a hand, please? A wonderful honor to have you with us. Thank you so much.
Thanks. It was a real pleasure. Bye-bye.
This next question is from a parent for the remaining 3 panelists. And by the way, thank you, all the parents that It was an amazing response from parents who want questions answered. A couple of the presentations touched on this, but I think perhaps there's an element of degree in this next question. What do parents do about children who resist treatment, especially college/adult children? And I think the context may, we talked about ODD, and then there's an element of potential physicality or violence. So for example, I was just talking with a parent who said, this is fine, it's all I can deal with for my 5-year-old, but pretty soon that 5-year-old is going to overcome me, and I have to be concerned about his safety, the safety of siblings, etc. So I think a lot of parents, from what I hear in their interactions, are concerned about not only resistance, but resistance evolving into something more threatening.
Well, that's obviously a good question, and those of us who are working this area would argue again for trying to identify people early and having earlier intervention. In some ways it's less complex because it hasn't yet gone necessarily to all aspects of the person's life. We had a really shocking surprise when Dr. Miklowitz and I were working together at the University of Colorado. We decided to do a relapse prevention study for students coming to college because we know that 55% of the people who were depressed in high school have a relapse during the first 2 years, and a goodly percentage of those people drop out. And this was really shocking, and I'm answering this in regards to as children grow up. The one thing that was incredibly characteristic of those people who had a relapse was that only 11% of the people who were taking antidepressants when they left home continued to take them when they moved into their dormitories. And that could be offset with a psychosocial intervention that was geared toward adaptation based on a combination of CBT and interpersonal therapy. But I think the parent that raised this question has touched on to something really interesting, and that's, what do you do? We recently, for example, had a set of parents who had a daughter going to the University of Georgia, had a history of depression. She went to college, she started to get depressed, and they had to fly down and literally almost physically bring her to our clinic. And then the mother stayed, and after the second or third session, and we were able to put her on a combination with our young adult psychiatrist and a good cognitive behavior therapist. And the good news is now she's back in school and she's making very good grades. But it took the family actually staying involved and intervening directly, because this newness of life when you leave, even to go to boarding school or to go to university, is a really critical time. And one more comment, that there was some really good work done by a sociologist at the University of Minnesota that showed that these people who had some symptomatology early, for example, with the slide that Kate showed, the very first one, of the 3 to 6 year olds, at each transition there was a blip up in the same children of re-experiencing the symptoms, at least, if not the disorder, of anxiety and depression when they go from middle school to junior high to high school, and high school to university.
Mm-hmm. Yeah, so I'm not sure the degree of severity that was mentioned in that question, and also the age. It kind of sounded like it was a question about potentially development, like shifting strategies, if you will, at different ages. And so I'm gonna take that. I think it's really critical that families stay involved. I love that point. And kids who are like the young adult, that they're functioning but not so well. There's a lot of kind of motivational strategy that goes into helping that person get the treatment they need. But I'm going to focus for just a minute on sort of the other end of the spectrum, really at any age. What we're told as mental health professionals, if a child or any individual is at risk of hurting themselves or someone else, that is the one place where we would break confidentiality and we would call for a higher level of care. So I think the same thing applies to parents. I mean, if you're really worried that your child is at risk of hurting themselves and they won't go to treatment, or that your child is going to hurt somebody else, whether it's their sibling or whether it's you as the parent, I think it calls for sort of bringing in the authorities, just as you would do. So for example, if you have a child that's beating up their younger sibling and you're terrified that they're gonna physically injure, and maybe this kid is, 80 pounds, 120 pounds, the one that's doing the beating up, I think sometimes you have to call the police and you get them to a hospital and you get them the help they need. But so that's kind of an extreme example. But if it kind of crosses that threshold to at risk of hurting yourself or someone else, sometimes that sort of a more directive approach may be required.
That's a good point.
So I think Kate's point is, of course, absolutely crucial. So if there's a real risk of harm to yourself or to others, then there needs to be a pretty robust response of the form that Kate's mentioned. If it's more that your child is clearly very unhappy, is pretty anxious or pretty depressed, but they don't seem to want to have any therapy, then I think it's important to realize that in all the clinical trials of these problems, if you have someone who goes on a placebo tablet or on a wait list, so no treatment at all, a large number of them will recover in any case. So there's a lot of natural recovery for these conditions. So you shouldn't think, the only way in which my child is going to overcome this problem is through therapy, because that's not what the data in general shows. And people often grow out of these things as well. And also, just because someone doesn't want to have an intervention now, it may not make sense to them, or for other reasons they don't want to, it doesn't mean to say that there won't be a window of opportunity further down the line if they haven't just naturally recovered. So don't panic.
Don't give up hope. We have time for one more question. This is from an LMFT. Thank you. We talked about a lot of new treatments and therapies that are being developed. Many thanks to AIM and the doctors here. Thank you. How will these treatments get to the kids who need them, especially to kids who may, especially to those who may be from low-income families?
Yeah. Well, the answer is different depending on the environment. The way that we've tried to address that is we have a scholarship program for the people who have no insurance and no money, but of course that's on a very small scale. And on a larger scale, it's going to require the availability of these treatments. We have a lot of data now about effective treatments, and Dr. Clark probably spelled those out more clearly in terms of listing several of them. For the anxiety, the same thing's true with depression, where there are at least 3 psychosocial interventions that have essentially equal effectiveness. But it's a serious problem in our country of people without insurance and people who have the inability, it's more than that, but the inability to get to the services. And I think one of the ways that's being addressed is through the use of digital medicine, and we've had a lot of discussion of that this week, although we don't know yet exactly if that's going to be equally effective. Because we're short in time, I'll stop. There are several other things, but yeah.
I would say 2 things to add to this. I think through our school systems, I really believe in taking therapy to where kids actually are, and it can be at multiple levels. It's prevention. Thank you. Prevention as well as intervention. So what do I mean by that? I mean, just as you might take, math or English, or why don't we have just standard education on how to manage your mood, how to manage your anxiety, how to manage your behavior so that you have healthier habits, and that could be preventive in the long run, as well as intervention. So for example, whether it's the novel intervention like the one I presented, Camp Kid Power, or whether it's evidence-based effective treatments that have been more studied very deeply, such as cognitive behavior therapy, to train personnel in the schools, and then probably also through primary care pediatrics. But the schools, to me, seems to be the lowest hanging fruit.
So I'd very much agree with Kate. For children, it's really good to get to where they are. In England, we're just starting a program where we're creating what we call mental health support teams in schools, and they are well-trained psychological therapists who are based in schools or close to the schools, so that children don't have to go to a specialist unit, which might seem very stigmatizing to them, and they can be picked up in the school environment. That program is just starting, but the reason we're doing it is because we've done something very similar with adults, where we have a very large program called Improving Access to Psychological Therapies, which currently sees 1 million people a year and provides them with evidence-based psychological treatments. The key there is to have a sort of national program where you train therapists to deliver these treatments well, because psychological treatments are much more difficult to deliver than medication. The medication has always got the same amount of chemical in the tablet, but a psychological treatment, unless it's delivered by someone who's really well trained to deliver it, is essentially just a placebo, and you're not going to get the best results. So we created a national training program for that, and we are getting the results that you see in randomized controlled trials, but in vast numbers of people. It costs quite a lot of money. Currently, I think it's about $700 million as a national program. And you might say, well, where does that sort of money come from? Well, it came from a straightforward economic argument, which is that certainly in adults, you save more money than it costs you to deliver these psychological treatments. That's because if you're anxious or depressed and in the workplace, then your mind is often somewhere else. It's on your anxiety and your worry. You're a lot less productive. Your company has to employ more people. You might be out of the job and you may be getting benefits of some form for that, and that's also costing society a lot. But there's another thing, which is you have much higher physical healthcare costs. So say you've got depression and diabetes, a very common co-occurrence. It costs 50% more just to treat your diabetes than if you weren't depressed. And that extra cost of treating the diabetes is so large for most people that actually that's equivalent to the cost of a course of psychological therapy. So that's why the British government has launched such a big program. It has a sort of unique feature to it, which is public transparency. So everyone who's treated in the program has their outcomes measured, and if you're a consumer, you're someone in the community who has a mental health problem yourself or has a friend that has, you can Google a website and you can see the outcomes of the local Improving Access to Psychological Therapy service, and you can look at whether the one in the equivalent of Monterey is doing as well as the one in the equivalent of Seaside, and you can make a choice about where you want to go. And this really empowers members of the community to get involved in really looking at things. But also, if professionals step up to the plate and allow their outcomes to be publicly reported, we all learn a lot from it. So we find that some services delivered by experienced people, well-trained, aren't doing as well as others. And we then try and understand what's going on there. And we've found that we can use that information to improve the standards in general. So that program, which has been running for 10 years now, is really the prelude to the program we're just starting in schools, which is based on the same principles of properly trained therapists giving treatment to people near where they are, and recording and publicly reporting the outcomes. If any of you want to lobby for that sort of initiative here in California, there is a book we wrote called Thrive, How Better Mental Health Care Saves Lives and Saves Money. You'll find all the arguments there. And I think the prospects for something like this in California are really substantial, because you have this wonderful thing that we don't have in England, which is your millionaire's tax. And it does generate a very large amount of money for mental health. But I'm not sure at the moment whether it's being necessarily used to promote evidence-based interventions in a publicly transparent way. But one of the wonderful things about California is you get to vote on so many different things in different propositions. And you have democracy in a wonderful, healthy state. And so you have an opportunity.
Just following on what David said, I didn't talk about it, but obviously the school prevention programs that I alluded to earlier, we're looking at things like the cost, and the cost of a person who stays depressed as an adolescent as versus prevention. Just the medical, there's 4 times the use of medical services, and over 2 times the use of substance abuse and tobacco smoking, which has long-term health implications. So it's just an example of what you're talking about on a smaller scale, but clearly where the opportunities lie with these children who are at risk is in prevention, identifying people at risk in the school. And one nice thing about the project in Sweden is we've been able to bring the schools and the healthcare systems together, though they weren't talking to each other very much, and that's also true we found here. So I think that's a grand opportunity.
And there are really good economic arguments for making treatments more widely available for children as well. You saw in our data that if you treat social anxiety, children are able to concentrate much better in the classroom, and they get better grades. Well, that has an enormous impact on society. Obviously, if we're training a much better educated workforce, that has a vast impact on our economy.
Well, I lament greatly that we are out of time, but please give a hand to our panel. Thank you. I'd like to wrap up by saying, gosh, this has just been such an exciting morning. Thank you for taking time out of your busy work and school day. No, several seniors are here, right? They had AP finals the week, and now they're done with that. We got congratulations. We have many more questions submitted than we can answer, so please follow us and like us on Facebook. We will be following up with your questions. We'll partner with our Science Advisory Board, and we'll make sure that we get responses to your questions over time. Thank you very much. I want to just reiterate what AIM does that is unique. I've been in the nonprofit sector for a long time, and when an organization tries to convince me that they're unique, I usually don't believe them because there's usually some organization out there that is sharing a lot of mission overlap with very few exceptions. I've not come across an organization like AIM in terms of its funding model. We strive to reinvent the efficacy of research funding, and where we can be of help is fueling research that helps children now. How do we do that? Well, I'll tell you how we do that. Our amazing science advisors spend probably 30 to 40% of their time, if not more, writing grants to government administrations that may or may not get funded. I think Tom Inzel said, 13% chance of success, perhaps, of the second cut. That's a lot of time that you're not focusing on children and outcomes. And so how we fund is to get those monies right in the hands of researchers to do research now that helps children. And quite frankly, nobody in this field got into it because they love doing paperwork. They love helping children, and so that's our model. We reward our friends up to the north in the tech sector, right? We encourage them to take risks, to be innovative, to fail quickly and forward, and then learn from those failures, and then come up with real innovative problem-solving models. We need to take the same approach in helping children who suffer from mental health crises, and we aim to be a part of that solution. So that is all possible with your help. So thank you so much. I hope that you've had an extraordinary morning and that you'll join us for another event in the future. Thank you so much.